Hello everyone, my name is Stephen Alsop and we have come to the final section of neurology. So now we'll talk about some of the drugs that can be used to treat some of the diseases that we've been talking about. We discussed glaucoma earlier in the lectures. It is the condition of increased intraocular pressure due to impairment of aqueous humor flow. So now if we look at this diagram, you should be able to remember that aqueous humor is produced by the ciliary body in the posterior chamber. It then travels to the anterior chamber through the pupil. It is then resorbed at the canal of Schlemm. So if we think about this, sympathetic drive stimulates beta receptors on the ciliary body to increase the production of aqueous humor. At the same time, it also stimulates alpha-1 receptors so that the pupils dilate. Meanwhile, you have the parasympathetic system, which drives the ciliary muscle, causing pupillary miosis, which is basically shrinkage. So now let's think of a way that we can remember what the roles of these two systems are in terms of closure and opening of the pupil. Let's say you were being chased by a bear. This is my angry bear. The role of the sympathetic system here is fight or flight, right? And so it makes sense that in this system where you have to have some rapid response to a possible threat, you want the pupil to be as wide as possible, because in that instance, you're able to get as much visual information into the eye as possible. Of course, it really isn't that simple, but this is a good way to remember how the sympathetic system affects pupillary size. And by converse, you'll know that the parasympathetic system does the opposite. Once you understand the pathogenesis of glaucoma, it can be easier to remember which drugs are used to relieve the increased intraocular pressure that occurs. Alpha agonists such as epinephrine and brimonidine decrease aqueous humor production. However, as you may remember, epinephrine cannot be used in closed-angle glaucoma. Why is this? You should remember that epinephrine causes mydriasis, which is simply dilation of the pupil. When the pupil dilates, this further closes the angle at this point here, and that exacerbates the problem of closed-angle glaucoma. Beta blockers decrease the production of aqueous humor, and they may also help to reduce secretion. There are no ophthalmic side effects, but timolol is the most likely drug to have systemic side effects. In patients with a normal nasolacrimal duct, the eye drops can drain to the nasal mucosa and be absorbed directly into the bloodstream, bypassing the hepatic metabolism that would usually affect timolol taken by mouth. Diuretics like acetazolamide reduce the amount of aqueous humor produced as well. I think you can see a common theme between all of these drugs that I've mentioned so far. Acetazolamide works through the inhibition of a certain enzyme. Do you remember what enzyme that is? Carbonic anhydrase. You should remember that from your renal lectures. Cholinomimetics are so named because they mimic the action of acetylcholine. They can do this in a direct manner by acting on the same receptors as acetylcholine, or they can do this in an indirect manner by inhibiting acetylcholinesterase, which usually breaks down acetylcholine. Both direct and indirect cholinomimetics cause miosis, which thereby decreases flow to the anterior chamber and contraction of the ciliary muscle. This opens up the trabecular meshwork, allowing more aqueous humor to be resorbed. Lastly, the prostaglandin analogs like latanoprost increase outflow through the canal of Schlemm. These drugs are now widely used as the first-line therapy, so you should remember that. These are first-line for glaucoma. Opioids are a class of drugs used to control pain, hence analgesia. They are most commonly used for moderate to severe visceral pain, such as in the post-operative state. They act on opioid receptors, right? Hence the name. There are three types of opioid receptors. You can have mu receptors, delta receptors, and kappa. Just remember this like if it's a fraternity, mu, delta, kappa. Most opioids act at the mu receptor. All three opioid receptors are G protein coupled receptors. When activated, they decrease cyclic AMP, increase potassium conductance, and decrease calcium conductance. The net effect of the changes in potassium and calcium conductance is to decrease the neuronal transmission of pain. You should also know that opioids can be either fast-acting or slower-acting. Fast-acting opioids like heroin are associated with a higher rate of addiction. Methadone is used as a treatment for heroin addiction because it is slower acting and therefore less addicting. It can act to bridge the patient from heroin towards the goal of no opioid use. Morphine is sometimes used in acute pulmonary edema, where the anxiolytic effect reduces the sensation of dyspnea and allows better synchronization with the ventilator. Dextromethorphan is an opioid used to suppress coughing. It's an active ingredient in over-the-counter cough medications like Robitussin and NyQuil. Because constipation is a side effect of opioid use, they are frequently used by doctors to treat diarrhea. Now, the most dangerous sequelae of opioid overdose is respiratory depression. This can lead to death, so you should know what the treatment is for an opioid overdose. What is it? The answer is naloxone. You need to give naloxone or naltrexone, which are both antagonists at the opioid receptor. Patients on opioids will also have pinpoint pupils, altered mental status, which means they can be stuporous or even comatose, and they'll also have nausea or vomiting. I just want to mention quickly that in general, you should really know what overdose of the major drug classes will lead to, especially for neuro, renal, and cardiology. Not only that, but you should also know the course of action for each overdose. This is key and will lead to easy points on the exam. Commonly tested principles of opioids are tolerance, dependence, and withdrawal. Tolerance develops to most effects of opioids. Essentially, the more doses of drug you give, the less effect each dose has on the patient, right? In order to achieve the same amount of pain relief, you have to give even more of the drug. The only effect of opioids that do not develop tolerance are constipation and meiosis. That's a nice fact for you to remember, as it is often tested. Now, in the hospital, anytime you prescribe opioids, you should also prescribe a bowel regimen to avoid constipation and all the sequelae of that. So now let's move on to dependence and withdrawal. Dependence is a state in which the body has adapted to the presence of the drug and requires it for normal function. So with dependence, now you need it just to feel normal. So tolerance, greater drug leads to less effect. Dependence, you need it now for normal function. Withdrawal, I'm sure you're familiar with, but you have a number of ill effects as a result of not being able to take the drug. So these things can often go together, and especially with opioids, which has a high potential to be a drug of abuse, you have to be very careful about prescribing these drugs for outpatients. However, this is an important key concept that you will probably run into on third year. You should never withhold opioids from patients with a legitimate reason for pain simply out of fear of producing addiction. So this really is a balancing act. You don't want to withhold the drug from patients that need it. However, you don't want to give too much of the drug because you don't want to produce addiction. Because remember, if the patient does become dependent on opiates, then abrupt discontinuation, such as when they're discharged from the hospital, can lead to a host of withdrawal symptoms that would include muscle aches, sweating, diarrhea, dilated pupils, and of course, nausea and vomiting. Butorphanol's trade name is Stadol. It's important not so much for what it is used for, but rather to illustrate the concept of partial agonists. Butorphanol is a partial agonist at the mu receptor. It has a lower efficacy at the mu receptor than full agonists. Morphine is a full agonist also at the mu receptor. So what happens? Well, in the presence of a full opioid agonist, butorphanol competes for mu receptors with morphine, but it isn't as good at activating the G protein coupled receptor, so there's less of an opioid effect. Taken to the extreme, this can cause withdrawal symptoms if the patient was previously taking a full opioid agonist. It is as effective as morphine when it comes to relieving moderate pain, but it is less effective for alleviating severe pain. Butorphanol is also a mixed action opioid, meaning in addition to binding at the mu receptor, it also binds to the kappa receptor. The good thing is that butorphanol and other partial agonist drugs have less likelihood of causing a certain side effect. What is that side effect? Respiratory depression. So you have less respiratory depression with partial agonists. Tramadol is yet another opioid agonist, but it acts on other receptors as well. It inhibits serotonin and norepinephrine reuptake, meaning that it enhances the effect of those neurotransmitters. We talked about serotonin and norepinephrine. You can think of it as causing more norepinephrine and more serotonin to exist at the synaptic cleft. Tramadol is used for chronic pain syndromes and has a similar side effect profile to opioids. One important thing to note for tramadol is that it lowers the seizure threshold. So in a patient who may have a propensity for seizures, tramadol may push them over the edge. Okay, it is time for a flash quiz. In a patient with closed-angle glaucoma, what drug should be avoided? Epinephrine cannot be used in closed-angle glaucoma because it causes mydriasis. We discussed that this closes the angle of the trabecular meshwork and the canal of Schlemm, which will exacerbate the problem of closed-angle glaucoma.